Staring at a textbook full of cardiac medications and protocols can feel like trying to memorize a foreign dictionary in a single night. The volume of side effects, contraindications, and dosing rules is enough to cause your own tachycardia. You do not need to memorize every single detail to pass. We are going to replace that frantic search for facts with a simplified framework built on one strict principle: keeping the patient alive. Give me 6 minutes. By the end of this video, you will confidently apply this framework to solve 5 high-level NCLEX practice questions. Success on the NCLEX depends on recognizing that test makers prioritize patient safety over rote recall. They are checking to see if you can identify exactly which clinical actions prevent a lethal outcome. Step 1 is grouping the core medications by their primary action and their biggest red flag. We start with beta blockers, which end in lol. These decrease heart rate and blood pressure. The critical safety warning to watch for is that non-selective types like propranolol can trigger bronchospasms. You must avoid them in patients with asthma or COPD. Next are ACE inhibitors, ending in pril. These act as vasodilators. You need to distinguish between their side effects. A dry, persistent cough is expected, but swelling of the face and lips indicates angioedema. That is a life-threatening airway emergency. If a patient cannot tolerate the ACE inhibitor cough, they are switched to ARBs, ending in sartan. The absolute safety rule here is that they are entirely contraindicated in pregnancy. Calcium channel blockers lower both heart rate and blood pressure by relaxing blood vessels. The major testable warning for this class is a strict rule to avoid grapefruit juice, which increases serum levels and leads to dangerous hypotension. This reference guide highlights nitroglycerin under the vasodilator section. These are massive vasodilators used to treat acute angina by rapidly dropping preload and afterload. The severe risk is profound hypotension. The strict rule is a maximum of 3 doses, spaced exactly 5 minutes apart. Diuretics remove fluid, but the safety check is entirely about potassium shifts. Loop and thiazide diuretics deplete potassium, creating a high risk for hypokalemia. Potassium-sparing diuretics do the opposite, risking hyperkalemia. For anticoagulants, you must link the drug to its monitoring lab and antidote. Heparin requires monitoring the APTT, and its antidote is protamine sulfate. Warfarin requires monitoring the PT and INR, and its antidote is vitamin K. Antiplatelets, like aspirin, prevent clotting. Your primary nursing action is monitoring for signs of internal bleeding. You must assess for dark tarry stools due to the risk of GI bleeding and hemorrhagic stroke. Finally, the antiarrhythmic adenosine. It converts supraventricular tachycardia, but causes a brief, expected period of asystole. Because of its extremely short half-life, it requires a rapid IV push. Across every medication class, the test evaluates your ability to anticipate and prevent the most dangerous potential outcome. When treating a myocardial infarction, the standard protocol follows the MONA acronym: morphine, oxygen, nitroglycerin, and aspirin. Note the critical nuance. Oxygen is only administered if the patient's oxygen saturation drops below 90%. For any acute cardiac event, there are 2 universal baseline interventions you execute immediately: secure intravenous access and initiate continuous cardiac monitoring. This table outlines dysrhythmia treatments and absolute rules for shocking. Defibrillation is an unsynchronized shock for pulseless rhythms. Synchronized cardioversion is strictly for unstable rhythms with a pulse. For bradycardia, pacemakers are indicated when a patient is symptomatic and unresponsive to atropine. Knowing the mechanical status of the heart, specifically verifying if a pulse is present, dictates the line between a life-saving shock and a lethal error. Now we establish the universal hold parameters. You will always hold beta blockers, calcium channel blockers, or digoxin if the heart rate is under 60. You will always hold vasodilators if the systolic blood pressure drops below 100. The immediate goal during an ischemic event is reducing cardiac workload. If a patient reports the onset of chest pain during exertion, step 1 is always to stop the physical activity immediately. You must scan for absolute red flags that require rapid intervention: facial swelling indicating angioedema, a sudden severe headache in a patient on blood thinners suggesting intracranial bleeding, or extreme potassium derangements that risk cardiac arrest. In cardiac nursing, proactively choosing to withhold a medication based on your assessment data is frequently your most important clinical action. Let's test these pathways. If a patient develops chest pain while climbing stairs, you instruct them to stop the activity and rest. If you check vital signs and find a heart rate of 52 before administering metoprolol, you hold the medication and notify the provider. If a patient's monitor shows symptomatic supraventricular tachycardia, you initiate vagal maneuvers, followed immediately by a rapid IV push of adenosine. If a patient on warfarin has an INR of 4.8 and reports mild gum bleeding, you hold the warfarin and notify the provider. Mastering these direct if this, then do this clinical pathways forms the core logic required to pass priority-style questions. Let's apply this logic to 5 NCLEX-style questions. Question 1 asks for the correct teaching for lisinopril. Because we know ACE inhibitors act as vasodilators that lower resistance, we know the correct answer is that the medication reduces the workload on the heart. Question 2 asks which lab value is most concerning for a patient on furosemide. We know loop diuretics deplete potassium. Therefore, a potassium level of 2.9 is the immediate safety priority, as it risks fatal arrhythmias. Question 3. A patient on an IV diltiazem drip develops severe bradycardia and hypotension. The primary threat is decreased cardiac output, so the priority intervention is to stop the infusion immediately. Question 4 asks for the priority instruction when taking sublingual nitroglycerin. Because this drug causes rapid vasodilation, the safety risk is orthostatic hypotension. The patient must be instructed to sit down before taking the medication to prevent a fall. Question 5 is a select all that apply for an acute MI. Applying the targeted ischemia protocol, we administer nitroglycerin, obtain troponin levels, and initiate heparin. We explicitly rule out ambulation, which increases cardiac workload, and we withhold oxygen because it is only given if saturation drops below 90%.